pancreatitis, should the diagnosis of autoimmune pancreatitis be ruled out in all cases, and voted upon if no other etiology of chronic pancreatitis can be identified in a patient, then a diagnosis of autoimmune pancreatitis should be ruled out. And it's quite easily, so there is weak evidence and also weak recommendation. Okay. Another question here is there a recommended classification system that should also be used when defining the etiology? And the short answer is no. The fun part of being involved in these guidelines really also is, if it's done well, it will create questions which can be answered in the future by us, by the community. And therefore I would really encourage you, maybe not that much read this, but it will be the newest coming out later this year, but to really look through the statements and the comments for the things you're interested in, and then come forward with ideas how one could really possibly correct these kind of deficits, which are always obvious when you are coming to do these kind of guidelines. Then maybe here in the end are the different causes of the disease, and of course, depending on the etiology, chronic pancreatitis has different disease causes and long-term complications. Strong agreement, grade 1B. Okay, so that's rather good already. For the diagnosis, then, what is the best overall imaging modality for establishing a diagnosis? Endoscopic ultrasound, MRI, and multi-detector CAT scan are the best imaging methods for establishing a diagnosis. Grade 1C, strong agreement. And then there will be comments going into the details and even nice tables, which will give you the evidence so that you can easily see what is the evidence for making this statement. Yeah? For the classifications then, CAT scan is the most appropriate, and there is not that much evidence, not that much recommendation, but a very strong agreement from the group. And for instance, one of the things where we also wanted to make something new, which hasn't been picked up by the other guidelines, is the secretine MRCP. The use, what advantage does IV secretine administration provide during the MRCP examination for the evaluation of chronic pancreatitis? And then the statement, the use of IV secretine increases the diagnostic potential of MRCP in the evaluation of patients with known or suspected chronic pancreatitis. And here, the evidence is maybe not that strong, but it was a strong recommendation and a strong agreement in the group. Okay, so that's how you interpret this. Then, as to the diagnosis of pancreatic exocrine insufficiency, how is EPI defined? And you heard some of that during my lecture yesterday, is an insufficient secretion of pancreatic enzymes and or bicarbonate function. And of course, this is excellent evidence, high grade of recommendation, and strong agreement. And then you heard about this yesterday from both my talk and the subsequent talks. What are the blood parameters to measure malnutrition? Established blood parameters for malnutrition: prealbumin, retinol binding protein, vitamin D, minerals, trace elements. And there is, again, not that much evidence and not that much recommendation, but a strong agreement on the statement as such. So, and then surgery. There's lots of surgery, of course, in the chronic pancreatitis guidelines, maybe not that much in the acute pancreatitis, so there is one of the areas where there was lots of expansions in patients with symptoms of chronic pancreatitis. Should endoscopy or surgery be performed? And then, there is good evidence for that, but a weak recommendation and only agreement due to the endoscopists in the panel. And the statement reads, surgery is superior to endoscopy in terms of mid and long-term pain relief in patients with painful chronic pancreatitis. And then you can read some more statements on the optimal timing for surgery. It should be done more early than late, because in late you wouldn't accomplish what you could accomplish when you do this early. There's, as you can see, through the bank, not that much good evidence, and the recommendation therefore is always weak. And the agreement for the most part is that no recommendation can be drawn from the evidence regarding the effect of early surgery on developing endocrine pancreatic function. Medical therapy then, and we covered some of that during my lecture yesterday. Again, for instance, for the dosing of the pancreatine, it's now between 40 and 50,000. Good evidence, high degree of recommendation, and strong agreement in the group. So, and then after all of this was done, and the group has worked several rounds again and again and again on the manuscript, it was eventually sent out to external referees who had the possibility from all disciplines to give their say on those guidelines, which they did. And after taking that into account, and this is also an experience I can share with you, some of those comments were indeed rather sound, and it's sometimes surprising to see that even with a huge and balanced group of experts, you sometimes miss a thing, which also means nobody is perfect, even not such a group of experts. Finally, then we went to the manuscript. And I hope this will be ready at latest for Vienna, if we are lucky also for the EPC in Liverpool. And please come to Vienna. Thank you for your attention.
Thank you, Matthias. One question from the audience. No questions? Thank you. Thank you.
Thank you.